All right. Hi, I'm Nicholas Gonsalves from Cedars-Sinai. I'll be presenting on operative approach and case volume are associated with negative resection margins for adrenocortical carcinoma. So I have no financial disclosure or conflicts of interest with the presented material. Adrenocortical carcinoma is a rare endocrine malignancy with poor prognosis. It has an annual incidence of 200 cases and 5-year survival of approximately 15 to 44%. Complete surgical resection of adrenocortical carcinoma with negative margins is the treatment of choice for patients with non-metastatic disease. The NCCN recommends open adrenalectomy as a standard of care for ACC, as laparoscopic adrenalectomies have been associated with unfavorable outcomes. Robotic adrenalectomies for ACC have not been assessed in literature. The purpose of the study was to determine factors associated with negative resection margins and whether operative approach affected margin status. The National Cancer Database was queried from 2004 to 2016, identifying 1,523 patients with AJCC or NSAT stage 1 through 3 ACC who underwent adrenalectomy. Operative approach was not available between 2004 and 2009, so these 642 patients were excluded from the study. 881 patients were included in the operative approach analysis. Also, 73 patients were missing margin status, so ultimately 808 patients were included in the margin status analysis. Patient, tumor, facility, and operation characteristics were compared by operative approach, open, laparoscopic, or robotic, and by margin status, positive or negative. By operative approach, there was no difference in age, sex, race between the groups. The majority of cases were done open, 65%, laparoscopically approximately 26%, and robotically approximately 9%. Patients undergoing open adrenalectomy were significantly more likely to have advanced pathologic T-stage or pathologic N1 disease. Patients undergoing open adrenalectomy were more likely to have tumors greater than 6 centimeters in size. The majority of cases were performed at academic centers, approximately 70%. Patients undergoing open adrenalectomy were more likely to receive treatment at an academic center or high-volume center. By operative approach, there was no statistically significant difference in margin status. Patients undergoing laparoscopic adrenalectomy were more likely to require conversion to open. So we looked at the trends of operative approach over the time period of the study. So the percentage of open adrenalectomies indicated by the gray line decreased over time. Robotic approach rates indicated by the blue line increased over time, and laparoscopic approach indicated by the orange line stayed relatively the same. Now looking at tumor characteristics by margin status, there was no significant difference in margin status by demographic factors such as age, sex, race. Patients with positive margins were more likely to have advanced T-stage. There was no significant difference in margin status by tumor size. Also, there was no significant difference in margin status by facility type, case volume, or operative approach. So in multivariate analysis, factors associated with significantly higher odds of positive margins included pathologic T3 disease, pathologic T4 disease, and laparoscopic approach. Note that the robotic approach was not associated with significantly higher odds of positive margins. High volume centers were associated with lower odds of positive margins. So in conclusion, centers with higher ACC case volumes are more likely to utilize open adrenalectomy in the management of ACC and have lower odds of positive margin status. Laparoscopic adrenalectomy is associated with higher odds of positive margin and conversion to open, whereas robotic adrenalectomy is not. So these factors should be considered when planning the operative approach for ACC. Thank you.